Historically, there have been confusing variations in the way health and social care professionals describe people with palliative care needs. In order to ensure that the right care is being given to the right person at the right time, the Fife Specialist Palliative Care Service have introduced evidence-based tools to help identify and describe palliative care needs. The Palliative Performance Scale, PPS, and Phase of Illness, POI, when used together, are of great benefit with regards to accuracy in communication, prioritization of caseloads, workload assessment and planning, and prognostication. The Palliative Performance Scale, or PPS, is based on the Kanofsky scale but is more sensitive. It is used to measure functional status in deteriorating health conditions. The scale covers ambulation, activity and extent of disease, self-care, food intake, and level of consciousness/confusion. The scale is stratified into performance layers from 100% to 0%, and the professional using the scale reads the descriptors to find out the best fit functional status of the individual. There are no half-fit values, and the professional must use their clinical reasoning to assign a value. The focus of this tool is to monitor change in the functional abilities in order to recognize deteriorating health. The Phase of Illness tool focuses on the plan of care for both the individual and their caregivers. There are 4 stages: stable, unstable, deteriorating, and dying. If there is no plan of care, or indeed the plan of care is not meeting the individual care needs, then they are identified as unstable. Upon your assessment and interventions, once a plan of care is in place, they then progress into either the stable phase, if the plan is meeting their needs, or the deteriorating phase, if the plan will require regular reviews to ensure it is meeting all care needs. The dying phase is self-explanatory. Death is likely within a few days. Both tools are to be used as a point-in-time assessment. The individual can move fluidly up and down the PPS scale and in and out of the POI phases. Let's look at some examples of how these tools can be used to help your clinical practice. John is 68. He has COPD and lives alone. He attends regular appointments at the GP practice to monitor his plan of care. Although he has restrictions on his mobility due to shortness of breath, he is managing light activities at home, including his own personal care. He is eating and drinking well and has no issues with his memory. His PPS score is therefore 70%, and his POI is stable as his plan of care is currently effective. John has recently developed a chest infection and has returned home from hospital. It is causing him severe shortness of breath, making it difficult for him to mobilize within his home. Most days he sits in his recliner with his newspaper. Recently, home care have begun to provide services to help him with his activities of daily living, such as bathing and dressing. His sister and daughter, who live close by, check in on him each day and deliver his meals, but they have noticed that he is only managing to eat about half of what they are giving him. His PPS score has now dropped to 50%, and his POI is now deteriorating, as the plan of care will require regular reviews to ensure it is meeting his needs. This change in PPS and POI scores is significant and should raise red flags with the professionals looking after John. Perhaps it is time to start or revisit anticipatory care plans for DNA CPR discussions with John and his family. Alex is 38. He has acute myeloid leukemia. Despite aggressive chemotherapy, his disease has not gone into remission. He lives with his wife and children. 6 weeks ago, Alex was able to get to his kids' football matches and only required minimal assistance from his wife at home due to fatigue. His PPS score was therefore 50% and his POI was stable. His plan of care was effective and the correct support was in place for the family unit. Currently, they have made their living room into a bedroom for Alex as he is unable to walk to the bedroom. Over the past week, Alex has been totally bedbound, requiring total care for all his activities of daily living. Whilst he has been enjoying the food his family prepares, he is only able to eat a few bites and mainly drinks build-up drinks to maintain his nutrition. He is usually fully alert and orientated, but is sleeping more now during the day. Upon assessment, his PPS is now 20% and his POI is now deteriorating, or possibly dying. He will require daily reviews to ensure the plan of care is meeting the needs of the whole family. Some short examples of trickier to score cases could include Jenny, who is fully mobile and independent with all self-care at present. However, she has decided to have her artificial feed withdrawn. PPS is therefore significantly reduced to 20%, and POI would be deteriorating, as she will require a significant level of support to ensure an effective anticipatory care plan. David is physically capable of carrying out all self-care and some activities, but requires supervision and prompting due to decreased cognition. PPS is therefore 30%. The plan of care is effectively meeting all his care needs. The POI would be stable and could remain so for a lengthy period of time. So with all these examples, it is the clinical reasoning of the professional that is paramount to find the best fit for the individual. The tools are used to paint a wider picture for the individual and their unique circumstances. Remember, it is a point-in-time assessment. It is for the individual and their carers. It's fluid, can move up and down the PPS scale and in and out of the POI phases. The most important thing to be vigilant about is the change in the PPS and the plan in the POI. These changes should then prompt you, as the professional, to consider the following. Good open conversations with the patient and their caregivers about deteriorating health and what is most important to them now and in the future. Discussions around DNA, CPR and the anticipatory care planning, including preferred place of care and preferred place of death as appropriate. Timely communications with all other professional services involved within the individual's care.